Hello everybody, my name is Kat Bowser. I'm your resident fantasy therapist and welcome back to my channel. Those of you here for the first time, welcome. My name is Kat Bowser. I'm a licensed therapist. I'm also a writer working on my first two novels, a standalone and the start of a series. And on my channel, I like to talk about what I consider to be the heart of writing. That's the characters. And the heart of the characters is their psychology. So that's the angle I like to take with everything I talk about on my channel. So today is going to be a little different. This is a video I've actually been considering doing for a while, and given everything that is going on right now, I think this is an ample time to do it. With the unfortunate deaths in the Black community that are happening, the unfortunate deaths in the majority of the minority populations that have been happening for some time, and their understandable anger and rage, I think that it's part of my job to do what I can to help with that. And one of the things I find to be the most valuable is education. Now, being that I am probably about as straight a white woman as you can get, the first thing I'm going to say is listen to the minority voices. Listen to what they're saying. Listen to their complaints. And as I have said before in a couple other videos, is you need to listen to listen. Do not listen to respond. When we listen to respond, we stop listening. So that is the first thing I'm going to say. Secondly, one of the things I feel that I can contribute is, while I am not knowledgeable of necessarily everything that is going on with the police or everything else that these minority groups have to deal with, I am knowledgeable on the mental health system. And one thing that I have found a lot of people asking is, how can there be so much unfairness, so much racism, so all this stuff within a system? It exists in the mental health system. And that's what I want to talk about today. So first and foremost, the reason that I want to talk about this is because it's something I have knowledge in. It's something I have experience in. I have gone and done the research that I can, but as I always say with all my videos, I encourage you guys to do the research yourself. Go look it up. It's out there. So I can't give you guys everything, because in most of these topics there is a lot of research on it. So I'm going to try and just hit the most important points that I feel is important to get across to talk about this subject. And I like to talk about the mental health system because I'm a counselor, so I still feel the mental health system, it works, but it is flawed. It is inherently flawed because it was built on a flawed system. So what we can do is, I look at it as kind of like you would have, if you have a leak in your house, you call a plumber to find where the leak is before you can fix it. And that's what I want to get across with this video, is let's talk about what isn't working, how it got there, and then maybe we can start a discussion on what we can do about it. So there are a lot of biases within the mental health system. I wish I could sit here in front of you and tell you that there's not, but there are. First thing I want to bring across is everyone has what we call implicit bias. And what that means is we have subconscious or unconscious judgments that we make on people. And this is actually a survival mechanism, particularly if you've been through experiences where you were in danger. The brain tries to protect itself. So one of the things it does is it tries to find shortcuts. Like, okay, how can I protect myself from this scenario again? And unfortunately, sometimes what it does is it does what we call overgeneralizing. So if you were, say, put in danger by someone who happened to be of a specific race or of a specific gender, one of the things your brain might do is say, okay, whenever I see someone of this trait, I'm going to get nervous. I'm going to get unsure. I'm going to be a little more alert. And this is something that everybody has to some degree, and it can be influenced by your parents, by your environment, by your experiences, all kinds of things. So the first thing that we're taught in training is learn to recognize it when you have it. And when you recognize what it is, address it. Try to what I call cognitively reframe, like, okay, I'm having this reaction to this person. Is it based in logic, or is this something that is from my past experience that is clouding my judgment? And if that's the case, I need to fix it. Sometimes it's just reorienting yourself. Sometimes it's a little deeper than that, in which case we would suggest supervision for someone in the field. But that being said, those are implicit biases, and that's going to probably pop up a lot in this video. So first thing I want to talk about, bias in the mental health system: gender and sexuality. Biases against gender. Let's talk about, there has been definitely a bias against the female gender. For the longest time, up until I'd say about the early 1900s, women didn't have a lot of rights. They started to push for their rights around, they've been pushing for a while, but really started the push with like the Industrial Revolution and the Civil War and things of that nature. So one of the things that is worth noting at the beginning of the 20th century is that mental health could be used as a means of control for a woman. There was a diagnosis that they called hysteria, which has actually been noted in a lot of historical documents all the way back to like ancient Greece, ancient Egypt, which was basically a mood kind of sense, melancholy, that kind of thing. And what they started doing is they used to think it was what they called a wandering uterus, and that the uterus would move around. And so they used to have different remedies they would try. You guys have probably heard this story. Yes, this was about the time that we got essentially the invention of the vibrator, because women would go in and see a doctor, essentially get pleasured and would have an orgasm, and then they would go home. Needless to say, yeah, that's a pretty violating sexual assault, I mean, essentially. But that was considered the standard treatment. That's one instance. The other was, at this point in time, we did have essentially asylums where people who were deemed to be mentally unwell were put in these facilities and were essentially, honestly, just caged like animals. I mean, that's really how it kind of boiled down. But at this point in time, a woman, her husband could have her committed to an asylum for not agreeing with him, for speaking against him, sometimes for wanting to get an education. Yeah, there weren't a lot of recourse for women. Now, this changed over the years as women fought for and got their voting rights. They fought for and gained more independence. Then we had the sexual revolution. All these things contributed to women having more of a say. So what is the bias in the mental health system now? Usually it is on diagnoses. Women, for the most part, have been considered to have emotional disturbances. So one of the things that we find happens is that certain diagnoses are overdiagnosed. For instance, borderline personality disorder. More women are diagnosed with this than men across the board. And what's interesting is that men who show almost to the T the exact same symptoms are diagnosed with narcissistic personality disorder. Women have been, they did an experiment where they compared subjects who were men and women who were experiencing essentially the same symptoms. And the men would be diagnosed with PTSD, the women would be diagnosed with borderline personality disorder. And I think a lot of this still kind of rolls back to the women being considered overly emotional. That kind of internal bias and stigma is still there. Now, that doesn't mean that there is no justice in giving someone borderline personality disorder. If they have it, then absolutely they should be diagnosed with it. But it's being diagnosed too much. and it's being diagnosed with another diagnosis would be more accurate. So that is the main bias with women as of right now. Now, like I said, this is not an all-encompassing video, but I'm touching on the major ones right here. Let's just talk about sexuality. Bisexual, pan, homosexual, all that stuff. I'm gonna give you guys a really brief history. There's actually a lot of history to this. I didn't want to cover all of it, but I definitely think it's important to cover a lot of it. So up into the 19th century, sexual acts that were anything but for procreation were considered quote unquote unnatural acts. And they actually didn't get a secular law against them until about 1533, when Henry VIII passed a law criminalizing these acts. And this was actually done as kind of a power grab for the Catholic Church. And let's see here. And then about the beginning of the 19th century, we got the first time where homosexuality in particular, other sexual sexualities as well, but mainly homosexuality, was kind of put under fire as, should these people be held accountable because aren't they quote unquote unstable mentally ill? That's kind of where the start of is it a mental illness began. And the one thing that came out of this is it kind of pulled it away from the police and the state, and it put it with science and medicine. So not exactly a great leap forward, given that, you know, we don't want people with homosexuality, bisexuality to be considered mentally ill, but pulling it from the state was a step forward. I just wish it had happened in a different way. Okay. But in 1864, it was first suggested that homosexuality was actually natural, and it was a variant of normal human sexuality. And then we have a gentleman called Richard von Krafft-Beam. I'm going to say his name wrong because I'm really bad with German names. He initially considered homosexuality to be a hereditary degeneration, so something that was there at the beginning but was considered a quote-unquote defect. But what ended up happening is he actually did studies and worked with people that were homosexual. And by the end of his life, he rejected this notion and said that as far as he was concerned, there was no notion that these people were anything but sane and rational. We have Havelock Ellis and his wife, who was actually a declared lesbian, and they came up with this idea that it was, like I said before, a sexual variant, but not unnatural. And Freud even said that he considered it to be a possible normal development. He had different ideas on why that might be, and he was definitely off with some things, but he did not suggest that it was a abnormality. That came a little later. A gentleman by the name of Rado, he claimed that Freud's theory was based on faulty evidence, so therefore the idea of homosexuality and other sexualities being pathological got reintroduced. And this continued for quite some time. It became a quote-unquote mental illness in the DSM in, I believe, 1952. And then Kinsley introduced this idea of sexuality as a spectrum, and that even people who considered themselves straight had some, most of the time, had some inkling one way or the other. And then we had Evelyn Hooker, who presented a series of test results to psychiatrists and researchers, and half of them were from heterosexual individuals, half of them were from homosexual individuals, and the doctors could not tell them apart. And that was her push for, if you can't tell them apart, then how can you tell me that homosexuality means someone is not sane? Okay, we're getting near the end of the history here, but I think it's important. Then after the Stonewall riots, we had much more of a push to remove it from the DSM. And interestingly, there was a group of psychiatrists that would meet in secret, and they would present their findings and their push to remove homosexuality from the DSM to the APA. And one of the things that they did is they would actually show up cloaked with their faces hid, and they would say, I am a psychiatrist, I am also homosexual. And that was one thing that was a push. And eventually it was removed from the DSM. I believe the DSM-3, I believe it was removed. And they did replace it by what they called the sexual orientation disturbance, which was basically this idea of, if someone doesn't agree with their sexual orientation, then it's a potential issue. But that also changed over the years, and that was also removed. And then in the 1990s, the APA issued its first statement, and has continued to issue this statement continuously, that any treatment to change sexual orientation should be considered unethical and invalid. And there's also what they call I'm going to say this wrong, a caucus of gay, lesbian, and bisexual psychiatrists that started meeting in 1978 and working with the APA, and that is still active to this day. And the APA's official stance on what we call reparative, quote-unquote, therapy, because it's not therapy, is considered unethical, and it is not supported by the APA. So you can see there's been a lot of steps for different sexualities to kind of be accepted. And I think with this one, the main thing that is really causing issue right now is with the implicit bias that practitioners have. There is also an issue of insurance and getting coverage for mental health that causes issue for a lot of these patients that are looking to get therapy, medication, all that kind of thing, and they're being barred because of their sexual orientation. This is one of those that I think greatly varies depending on where you are. Some places have been very progressive in working with the LGBTQIA population. Can't think today. Other places have not. So one thing that is worth noting, though, is these individuals are much more likely to have PTSD, depression, and anxiety disorders. And that mainly comes from the stigma. That mainly comes from how they are treated and how they are often abandoned by their families and or friends when they do have the courage to come out, and they have to find new supports. Anytime that you are cast out of a family or a place where you have routinely gotten your support, that is anxiety producing, that is depressive inducing, that is traumatic. And that's what these people go through. And that's not counting the stigma that they still experience from society, because a lot of people are still clinging to these old ideas. And that is really where the bias for these individuals comes in, is the accessibility they have and just the implicit bias that practitioners can have. Hey guys, so I'm just throwing in a little extra content here because I knew I would forget something. So I want to talk transgender. So these guys have both the bias that you have with heterosexual sexuality, but they also have this additional bias of they usually don't even, they're not even usually really respected enough to be called what they want to be called. There is a lot of times people cite a legal mess about using their dead name versus their chosen name if they're in the middle of transitioning, things like that. And that is traumatic because these people are in a situation where they're trying to be treated how they feel. They're trying to be treated as the person they feel they are. And anytime that you're going to be using someone's dead name, which is their the name they were given at birth that they no longer associate with themselves, that is traumatic to them. And it is disrespectful. One of the first things I do in any session with anybody, regardless of if they're transgender or not, is I ask them, what do you like to be called? And I try to abide by that. There are maybe some instances where I have to use a quote unquote legal name for like insurance purposes and whatnot. But if it is within my power to use the name they prefer to be called, I'm going to use it. The other thing I want to clear up here real quick. A lot of times people use the fact that gender dysphoria is in the DSM to say, see, these people are mentally sick. No. Just because something's in the DSM does not mean that it is a quote-unquote mental illness. You know what else is in the DSM? Parent-child relationship problem. And what else is in there? Homelessness. Know what else is in there? Low or no income. All this stuff is in the DSM. It does not mean that it is a mental illness. It means that it's causing you distress, and it has to be addressed to resolve the distress. So as far as the APA is concerned, people who are transgender are perfectly sane, and they are capable of making decisions about themselves to make themselves feel better. And that is generally what transition is used for. So, like I said, these guys kind of get an additional bias just by nature that a lot of people don't understand or don't want to understand what they're going through. And that's unfortunate. Now, some companies are making strides to fix this. We're starting to see, instead of just male-female, we're seeing options for non-binary, we're seeing options for transgender, all that kind of stuff. So those are steps forward. My work, for instance, all of our bathrooms now are unisex. Anybody can use them. So there's little things like that that companies are starting to make. But I think we need to acknowledge that people that are transgender have not only the strain of the biases that naturally come along, unfortunately, with the LGBTQIA, but they also, more often than not, have trauma on top of it. And that's something that needs to be considered and addressed. Not to say other people in the LGBTQIA community don't have trauma. A lot of time they definitely do. But I do see it pop up more with transgender, and that's something that needs to be addressed and needs to be taken into account when you're working with that population. So that is sexuality. Like I said, we're not covering everything, but we're covering the main issues. Next bias, disability. This one hurt me when I did research for this one because there isn't a lot of it. I could not find a lot of research on it. There is a lot of research on mental illness itself being a disability for certain individuals. But when it comes to physical disability or what we call invisible disabilities, not so much. And I think that is unfortunate because, speaking as someone who has worked in this field since 2008, I've definitely seen it. So I know it's there, but the fact that there hasn't been a lot of research done into it disturbs me. So what can I tell you about this one? First of all, there's not a lot of research on it. There needs to be more research on this. the main thing that I have seen is a lack of access to mental health, a lack of ability to get to places, to have facilities available that they can reach, they can get to, having difficulty with what we call ableism, which is people have a more positive bias towards people that do not have quote physical quote unquote disabilities. And I say that because some disabilities are invisible, and that doesn't mean that the person is more or less disabled. It just means that we can't physically see them. And unfortunately, people judge by what they see a great deal of the time. And what we've found is that people, even people who have disabilities themselves, generally have rated individuals without disabilities as more positive than those that have them. And one of the ways that we have found that helps with this is exposure. A lot of times people are uncomfortable of things that they don't understand, things that they deem as not like them. And again, I wish that as humans we had a better approach to this, but what we have found is having people interact with individuals that have disabilities helps to reduce that bias. So that is something that can be done. The other thing is ableist language, and I brought this up I think in one other video. I can't remember exactly which one it was, but things like calling someone crazy, insane, saying someone is quote unquote bipolar, saying someone is wheelchair bound, things like that. These all create a sense that disability is something that is to be seen in a negative light. And it's kind of like I said with implicit bias. It's something that isn't there directly in your face, and it's usually very subconscious, and people do it without realizing they're doing it. And unfortunately, that colors people with disability in a very negative light. And so one of the things we can do is help eliminate and change some of those ableist language. And I think the best thing we can do with that is ask. Let's talk to the community, the disabled community. Let's see, okay, what is something we need to change? What is accessibility we need to change? What is what are accommodations we need to give you? All those kinds of things. I'll talk a little more about that when we get to the end. We talk about what we're going to do about this stuff. But again, like I said, I could not find a lot of research on this, and that bothers me. So I think we need to do some more research into the bias in this area, because I can guarantee you it's there. Okay, next one, race. So yeah, there is definitely a race bias in the mental health system. So kind of like I did with the sexuality, let's give a little bit of history on this one. So way back around before the Civil War, there was something called, which I'm going to pronounce wrong, phrenology, and like I said, I'm going to say it wrong. This was a belief that you could determine things about intelligence by the shape of someone's head, by certain dents here, and the way a skull felt, basically. And this was used to essentially justify that African Americans and other minorities were not as intelligent as white people. Now, this is obviously pseudoscience, and they actually knew that it wasn't supported as early as like the 1840s. But as humans are wont to do, they found that it helped justify some of their actions. So they still used it. They still talked about it. I think even to today, you'll still find somebody that mentions it every once in a while. And you have to tell them, this was, deemed inaccurate way back in the 1800s. Then we go a little further after the Civil War, and when African Americans were first being trying to build their lives in this world, and then started to fight for their rights, as they well should, against Jim Crow laws, against lynchings, against all these horrible things that were happening to them. And what ended up happening is, up until this point, the mental illness of schizophrenia was considered to be a white man's disease. It was an illness that was not dangerous, but was considered to make someone quote unquote unstable. What they ended up doing is, during the riots and during the protests, they started to call particularly black men schizophrenic, in that they were aggressive and obviously unstable, and them rejecting like they are proves that they're unstable. This still lingers to this day. It still lingers. Black men are almost double as likely to be diagnosed with schizophrenia than white men. One thing that you might often hear quoted is that minorities make up a majority of the mental health population. Well, they don't make up a majority. They do make up some of it. But what we have found is that minorities are much more likely to be told that they need to get help, because there seems to be more of a community within the minority populations. So any behaviors that are indicating a need for mental help are usually called out and attention is brought to it, as opposed to a white population. But the main issue with minority population and mental health is their ability to get it and the quality of the care once they get it. It is much more likely for them to drop out. It is much more likely for them not to be able to get the medication they need, not to get the therapy they need. They are much more likely to be involuntarily committed. And a lot of this goes back to a historical operation that occurred in about the 1930s, and we called it redlining. And what this was essentially city managers would draw out groups of areas of the city of, here is a good place for housing, here's where we can provide loans and mortgages, and then you would have the quote-unquote red lines where it was considered high risk, and that's not what you wanted to do. What they did, even though it was illegal to do so, that didn't stop them from doing it, was they primarily separated the minority populations from the whites and created essentially segregation. That still lingers. You can look at city maps even today and you can see the lower income areas are where the redlining was done. And that means a lot of times these families who were in these redline populations are still there, and they are suffering from lower income, less resources, less access to mental health. So that means when they do need mental health support, it's either not available, it's too expensive, or they can't access it. And that's a problem. That is a big problem, because one of the things that has been found is that when these populations do enter mental health, they're much more likely, if they get past the first couple of sessions, like with therapy, they're much more likely to stick with it, because there is this, like I said before, there's oftentimes this community support to help one another. Now, obviously, this is not a universal factor, but just in general. And the thing with these individuals being in these poor areas, these redlined areas, schools are not as good. Resources to the schools are not as good. That means that your education is not as good. Right now, about 2% of psychiatrists are minorities, particularly African American minorities. 2%. And it's not for lack of trying. It's for lack of these individuals having the opportunity to pursue school up to that point, to pursue college, to pursue a master's or a PhD. I will say I am seeing more counselors, so like master's levels, that are more diverse, and that's encouraging. But we need more within even the higher level, PhDs, psychiatrists, psychologists. And in order to do that, these communities need help. They need resources. They need an improvement in their education. They need help for childcare, all these things. And we'll talk about this in a minute. Last thing for the biases that I want to address. Socioeconomic status. I kind of started talking about this with race because it does connect. And that is essentially socioeconomic status is basically, do you live lower class, mid class, high class, below the poverty level. And across the board, lower socioeconomic status means that it is harder to get mental health. It is harder to pay for it. It is harder to stick with it. It is harder to get to it. Accessibility is the big thing. How can you get help for a mental illness that you have if you can't get to the therapist, if you can't get to the doctor? How can you get help for the mental illness that you have if you can't afford your medicine because you don't have insurance, or the insurance you have does not cover your medication? How can you get to work with a clinical team to provide you with resources and support if you don't have a means to get there, if you don't have a means to have someone watch your children so you can go? These are all problems that plague lower socioeconomic class. And that leads me into my last statement here, which is, what can we do about this? Like I said before, I love working in the mental health field. It is the most rewarding job I've ever had. And I continue to believe that we can improve it because I've seen it improved. If you look in history, way back at the beginning, when we used to put people in cages to try to spin the demons out, we stopped doing that. We used to throw people in asylums and just leave them there. For the most part, we've stopped doing that. We used to do lobotomies to make people complacent. Lobotomies, for the most part, have been outlawed unless you have a very specific reason and you have to justify it. So these things have all changed because people put in the effort to make them change, because people demanded that they change, because people said this needs to change. And that's what we have here too. I am lucky enough to work with a company that is what I consider pretty progressive, in that they are hiring individuals of minority races. They are hiring people on the LGBTQ spectrum. They are providing training from people of these populations, so that I'm not just hearing from some white person talking about it. I'm hearing from an individual that has lived through it, that continues to live through it. And that's one of the main things we need is education. We need training. We need people to interact with individuals, with these populations, and hear their stories, and hear what they need, and hear what their challenges are, so that we can find ways to address them. The accessibility is a huge thing. The insurance is a huge thing. Insurance is a problem in and of itself. Getting people involved with good clinical teams that can link them to support. So, for example, one of the programs that my work provides is career centers to help people get resumes, find better paying jobs. We provide people with training and classes on obtaining more coping skills, anger management, all those kinds of things. And what we need to do is we need to expand what's available. We need to make it so if someone who lives in a lower income area needs a crisis team, it's not going to take an hour to get them out there. We need to make it so that the mother who has 3 children but needs therapy can access her appointments without having to worry about care for her kids. We need to make it so that the schools have the same resources that other schools have. Right now, schools get, in the United States, get their resources from taxes, from property around them. But this means that people that live in poor income areas don't have as many resources because their property taxes don't make as much. In my mind, and again, this is just my opinion, but in my mind, each school needs to get an equal amount of funding, needs to get the same resources, the same amount of money, so that they can have well-paid teachers, so they can have repaired schools, so they can have extracurricular activities, all things that allow children to grow and pursue things like college or a master's degree or a psychology degree. That will increase the representation we have. Other thing, and I will say this is probably the one good thing I can say has come out of COVID: telehealth. We have seen a huge jump in telehealth, and because of COVID-19, the restrictions that usually prevent us from using telehealth have been lapsed, so we don't have to worry about them as much. This means that I'm able to access and talk to someone who needs therapy over the phone through Zoom. Just recently, there was a program in Arizona that clinical teams were able to provide their clients with a tablet so they could do interactive classes and therapy and that kind of thing. This is all great steps forward. They're small steps, but they're steps. And I really feel like interaction, education, resources, these are all things that need to happen to get the system better than it is. And these are all things that can happen. The other thing I mentioned, the wrongful diagnosis. You can challenge a diagnosis. If you get a diagnosis and you do not believe it was correct, or you believe that it was given because of biases, you have the right to challenge it. And in some cases, if you challenge it and you bring up that you feel that it was given under bias, it will be reconsidered and it can be striked from your file. These are things that not a lot of people know. And so that's why I'm presenting it now to you, to give you guys the information that I have. I also know that you can appeal to the APA, push for them to provide resources to poor communities, push for them for more opportunities to help parents with job, childcare, all those things, so they can access this. Push for laws about insurance and payments. These are all things that we can do, and it's going to take time. It's going to take a while. It's not going to be overnight, but they can be changed. Like I said, the mental health system has changed over the years. It has gotten better. It is still flawed. It still has issues. It still is in desperate need of some reformation in several places. But that means that it can be changed. And I think that is the most important thing that I want you guys to take from this video is we can change this. This is how it is now. Not everywhere, but these are some of the issues that exist. And we can change them. So that is just my video digging into the biases of the mental health care system. Like I said, this is varied. It's going to depend on where you're at. It's going to depend on your state. I'm basing all this because I'm in the United States. So if you're in another country, I don't know if this applies to you. But I did want to get out there the history of some of this and to kind of show how some of these things, some of these thoughts, some of these beliefs still linger. But that doesn't mean that they have to stay that way. It doesn't mean that we can't introduce training and better schooling to help fix this. It doesn't mean that we have to let it stay like this. We can make it better. Even right now, there's talk of integrated care within the next couple of years, where basically you'll have your counselor, your social worker, your doctor, all in the same building, so that they can all talk to each other and they can all work together to give you the best care that you can get. That is a big step forward. It's going to be a big change. A lot of, even now, the insurance people are arguing about it. How are we going to do this? But that will provide a means for, say, for example, someone who can only get away to go to an appointment once a week. Now we can nail it, all three, 1, 2, 3, right after the other. That's one thing that we can do. And I know I've probably been babbling this last little bit, but I do think this is important. And I do think that it is something that needs to be addressed and needs to be changed. And I do think that the mental health care system does help people. I do think that the work I do does help people. At least I hope it does. And I hope by giving you guys this information, it can give you ideas of what you can do to make it better where you are. So thank you guys for chiming in for my video. As always, if you have comments or suggestions, feel free to leave them below. And if you want to make sure you never miss when I upload, make sure you subscribe and ring the bell. And stay safe for all of you. And I will see you next time.